Well, good afternoon, everybody. So glad to be with you this lovely, lovely afternoon. As you can see, I am hanging out outside in my backyard because it's just such a lovely day. I had to come outside to do this. Also, I have a very loud and ornery dog that I'm trying to get away from. So, full disclosure. Um, but I am the section manager for Livable Communities. Livable Communities is a section at DAS, and mainly what we do is we oversee the Older Americans Act programs, and I'll be going through those programs one by one and giving you some key points to know about. And also, we oversee some state plans work and the Georgia Memory Net. So I'll be going through all of that with you today. So let's go. As always, our mission and vision is stronger families for a stronger Georgia. We love happy, healthy, active aging. Our team. So as I stated earlier, I am the Livable Communities section manager. We have the wonderful and fabulous Tom Snyder, who oversees case management and is also a team lead. And his four people that he oversees are David Watkins, who does caregiver and kinship, Megan Stadniski, who's over evidence-based programs, Almaz, who's over CSEP, the Senior Community Services Employment Program, and Yolanda Mendoza Miller, who does our in-home services, things like personal care, homemaker. She also does assistive technology. Our program assistant is Candia Al-Haddad. She makes sure that our section runs smoothly, that we have everything we need as program owners and as managers. And since today is Administrative Professionals Day, I'd like to give a big shout out to Candia. We love her, and I'm so glad that she's part of our team. And then we have Renee Brown, who is our chief dietitian. If you don't know what a dietitian is, it's basically like a registered nutritionist, somebody who has gone to school specifically for nutrition, did an internship, and is now registered and licensed in the state of Georgia to practice dietetics. She oversees three people. Those three people are Aline Stone, who's the GARD coordinator. GARD stands for the Georgia Alzheimer's and Related Dementias. They have a state plan on Alzheimer's and related dementias. So Aline oversees all of that work. We have Dr. Temi Tope Walker, who's our senior hunger nutrition coordinator. We have a state plan on senior hunger. And so she oversees that work, as well as the 12 senior hunger coalitions in Georgia that are associated at the 12 AAAs. And then we have Courtney Levy, who I believe is our newest employee on the Livable Communities team. And she oversees the Georgia Memory Net, which includes the memory assessment clinics and the contract that we have with Emory to do that work. So that's our team. So now what I want to do is I want to go through program by program and give you just a kind of a high level overview of what that means and what you need to know. So for case management, the contact for that is Tom Snyder. He did not put his email on this slide, but he's just tom.snyder@dhs.ga.gov. If you need to get a hold of him and can't, you can always get a hold of me. I know how to get him. And what he wants you to know are the key components of case management is, first of all, a comprehensive assessment. And one of the things that Tom always says is that we don't assess for services. We just assess the client for needs. And so sometimes where we get stuck is trying to fit a client into the array of services that we offer instead of looking at the client holistically, figuring out what they need, and then matching them up with the service. And so the other key component of case management is a person-centered service plan, and that goes along with the comprehensive assessment. Being person-centered means including the person you're assessing in the decision making so that the person being assessed has a voice in what kind of services they get, when they get those services, how much of the service they get, who the service is provided by, all of that sort of thing. That's a person-centered service plan. Excuse me. Case managers also work as a linkage to community resources. So we really expect our case managers to know a lot more than just what services we offer. They also should be involved in community and knowing what's out there. Maybe somebody needs help and a faith-based community could help them. Case managers should be the linkage to that type of community resource. And then also, not everyone who calls and asks for services is linked up with a case manager. Case managers are really brought in when an individual has really complex needs or is at high risk of institutionalization. And what we mean by institutionalization, for the most part, means a nursing home. Our goal at Livable Communities is to keep people in the setting of their choosing for as long as possible, so that they do not have to go into institutional settings like nursing homes. Case management is provided in all 12 of our AAAs, either in-house or via contract. So that's the overview of case management. And then we come to probably what is our biggest program, and that is nutrition. The contact for nutrition is our chief dietitian, Renee Brown, and you can see her email address. The one thing that I like to point out is she is Renee.Brown1, because there is actually another Renee Brown at DHS. But the goals of the nutrition program, and when I say nutrition program, I mean home delivered meals and congregate meals, but the goals of the program are first and foremost to prevent malnutrition, secondly to promote socialization, and thirdly to offer education and counseling. We provide what we call nutrient dense meals. Our meals meet 1/3 of the dietary recommended, the dietary reference intakes, which is basically the nutrition targets that we want to meet. We meet 1/3 of those because for the most part, we just provide one meal a day. And so we provide 1/3 of those nutrition targets, either by a home delivered meal. And a home delivered meal goes to a person who is homebound, which means they cannot leave their house without needing some kind of help, or they just flat out cannot leave their house. Or congregate meals. Congregate meals are typically served at a senior center and are done in combination with wellness activities, things like exercise, arts and crafts, games, even things like meditation, word finds, all kinds, anything that falls under the umbrella of wellness. Congregate meals served in senior centers also help combat isolation. And as we know, you may or may not have heard this, but social isolation is a very big problem, and it is very detrimental to your health. They say that being socially isolated is the equivalent of smoking 15 cigarettes a day. That's how bad it is for your health to be socially isolated. So we don't like that. We want people in their community. We want them participating and hanging out with others and doing fun things and living an enriching life. So nutrition, like I said, is one of our biggest programs. In state fiscal year 2019, we served about a little over 2.5 home delivered meals to about 15,000 clients. and a little over 1.5 million congregate meals were served to almost 16,000 clients. So we have lots and lots of people in the nutrition program through DAS. Next up, we have the caregiver kinship programs. Again, the contact for this is David Watkins. And what he wants you to know about this is that services for family caregivers can help reduce caregiver burden to enable longer caregiving and delay costly institutional care. So what we're saying here is that we know that there are a lot of caregivers out there who are not paid. Most of the caregivers in this country are family caregivers. And what we're trying to do with our caregiver program is to reduce caregiver burden. So what that means is caregivers sometimes start to feel overwhelmed by the amount of duties that they have to do for the care receiver. And we want to take some of that burden off of them so that they can continue to give that care and not end up putting the care receiver into a place like a nursing home. So one of the things that we do, first of all, is we assess our caregivers for burden, and that's called the Bacchus Caregiving Outcomes Scale. That's the assessment that we use. We also provide respite care services. Respite includes adult daycare, homemaker, personal care, home delivered meals, and other supportive services. So respite means that the caregiver gets a break, basically. And so the caregiver can leave the house, go run errands if they need to. Maybe they need to take care of their own medical appointments. Maybe they need to go to the grocery store, that kind of thing. And so the care receiver could go to an adult daycare, or we can provide services in the home to help clean the home, to help bathe and groom the care receiver. We can provide a meal and other things like that. We also offer evidence-based programs to caregivers. And those programs are called Powerful Tools for Caregivers, Benjamin Rose Institute Care Consultation, and the Rosalind Carter Institute Dealing with Dementia. Those are the 3 evidence-based programs that we offer around the state for caregivers to help reduce caregiver burden. And then we have kinship. When we talk about kinship care, we talk about services for grandparents, mainly grandparents, but it could be other relatives who are caring for children. And this can include support groups, material aid, things like groceries, gift cards, gas cards, things like that, even clothing, things like that, community and public education, and special events. So that's the Caregiver Kinship Program. Why is it not going?
I don't know. You just went on mute too. Did you mute yourself?
Am I back?
You're back.
Wow, I don't know what happened. My whole computer just sort of locked up there for a minute. Hang on, let me get back to the screen. Sorry, everybody.
That's all right.
There we go. Okay. Evidence-based programs. The contact for evidence-based programs is Megan Stedniski. And what are evidence-based programs? These are programs that have been evaluated and published in peer-reviewed journals. So basically what it means is that the interventions that are done in an evidence-based program can be replicated and the same results are expected over and over again. So we have been champions of evidence-based programs for a very long time. Georgia was one of the first states to adopt evidence-based programs, or EBPs, we call them. And we do a lot of them. We have the chronic disease self-management program, which helps people manage any and all chronic diseases. We have specifically a diabetes self-management program. We have a Spanish language tomando control de su salud, which basically is taking control of your health, and a diabetes education empowerment program. We also focus on falls prevention. If you guys don't know, falls are one of the leading causes of institutionalization. People fall, they break a hip, they break a leg, they go into a nursing home, and they never come back out. And so we focus a lot on falls prevention. So we have Otago, we have a matter of balance, we have Tai Chi. I don't know if any of you attended the Tai Chi program that was during the Lunch and Learn yesterday, but it was really great. And we also have bingo size, which is new to us. But it's a way of playing bingo and exercising at the same time. What older adult wouldn't love that? We also have the Aging Mastery Program, all the caregiver programs that I mentioned in the previous slide with David. And we have hospital transitions programs. So hospital transitions, this is a really interesting thing. We partner with hospitals. Well, we don't, the AAAs partner with hospitals to help prevent readmissions. And so when somebody leaves the hospital, especially an older adult, if they don't have the proper services and supports in place, they can end up being readmitted right back to the hospital. Well, that costs the hospital a lot of money. And with the ACA, now hospitals are getting dinged and fined for hospital readmissions. So what the AAAs do is they partner up with these hospitals and they say, okay, when you have somebody who's at high risk for readmission, we will connect up with them and we will provide those services and supports, whether they need a meal or whether they need personal care or homemaker services or whatever it is. They will provide that service and prevent that readmission from happening. So it's a really big deal. Not all AAAs have this program, but some do, and those who have it have been really successful at it. So it's a great program. So if you want to know more about evidence-based programs, and even if you would like to participate in an evidence-based program, you can get with Megan, or you can go to the website www.georgiahealthmatters.org, and you can see a list of all of the evidence-based programs, when and where they're being held. So really nice website. Okay. CSEP. CSEP stands for the Senior Community Services Employment Program. The contact for that is Almaz Akelwald. And CSEP is not funded by the Older Americans Act. CSEP is funded by the U.S. Department of Labor. And so the eligibility is just a little bit different. They serve adults who are 55 and older, whereas the Older Americans Act programs, as you learned on day one, I believe, is 60 and over. But these older adults who are 55 and over need to be low income and have very poor employment prospects, which means there's not a lot of employment opportunities out there for them. And so what happens is eligible people are placed in a part-time community services position with a goal of transitioning to unsubsidized employment. So what happens is CSEP subsidizes their employment income, but the goal is to get them on unsubsidized employment income. Participants receive paid training, they get new skills and experience, and oftentimes build their self-confidence. So it's a really valuable program. Host agencies do receive a temporary supplement at no cost to them, and employers have access to workers with high work what's the word I want to use? High work uh no, hold on. Ethics. Thank you. Had to move my screen. Okay. The Senior Hunger Initiative. We a few years ago, when was it? 2018, I think. We decided, maybe it was 2017. Anyway, I can't remember. A few years ago, we decided to make a big push to help reduce or even eliminate senior hunger. And we set off to make a state plan that addressed senior hunger. This was back in the days of Gwyneth Johnson. I was the chief dietitian back then. Gwyneth Johnson was the section manager. And we just had this big idea to address senior hunger. And the goal originally was to have our first senior hunger summit by 2019. Well, the commissioner saw our long-term plan and said, no way, we're doing this right now. So we had our very first senior hunger summit in 2016, 2017, and finished our state plan around senior hunger. You can read the state plan online. It's on the aging website if you're interested. It's not very long. And part of that was to hire a senior hunger nutrition coordinator. And so we've done that. Commissioner Crittenden has been very supportive of this initiative and was luckily able to find the money to hire a senior hunger nutrition coordinator. And that person is Dr. Timmy Tope Walker. She oversees the state plan, and as right now we're revising the state plan, so she's overseeing that work. She also helps oversee and provide technical assistance to the 12 senior hunger coalitions that are associated with the AAAs. And one of the things that she wants to know, if you can see the picture on the slide, the next Senior Hunger Summit is going to be June 15th of 2021. It will be virtual. Registration is open. So if you would like to register for the Senior Hunger Summit, it's free. You can just email senior.hunger@dhs.ga.gov. So some of the goals for this year is to complete and support the state plan recommendations of establishing interagency policy review council, coordinating data collection across state agencies, developing and providing education and training, and supporting the work of the Senior Hunger Regional Coalitions. We also have some data points that we're looking at around what the commissioner would say is moving the needle on senior hunger to help reduce hunger in Georgia. And so one of the things that we're looking at is decreasing the number of clients served through either congregate meals or home delivered meals who report eating fewer than 2 meals a day. We are working on developing strategies to reduce hunger in rural Georgia and setting a framework for the development of the next senior hunger state plan. So all great work that's being done by Dr. Walker. The next slide is around in-home. I think the next 2 slides actually are around in-home services. The contact for that is Yolanda Mendoza Miller. And there are quite a few services that fall under the category of in-home services. The first one being personal care, and that's assistance with eating or dressing, bathing or grooming, toileting, and transferring. Homemaker services, which can be assistance with meal preparation or shopping, managing money, In the most cases, it's light housework. There are also chore services, which is assistance with heavy yard work and or housework. Home modification and home repair, which are services to promote the safety and well-being for individuals to remain at home. So home modification might be something like removing the thresholds in the doorway so a wheelchair can get through them easily. Or home repair services. Maybe they have a leaky faucet or something like that. It's usually pretty minor stuff. We don't tend to do really big things like put on a new roof or something like that. It tends to be kind of minor stuff, but stuff that helps keep a person at home. In order to qualify, you have to be, again, 60 and over. And you must have a physical or mental disability which restricts your ability to perform activities of daily living or instrumental activities of daily living and have little to no support. Special emphasis is placed on people who live in rural areas, are in greatest economic and or social need, and have severe disability. So that's all the Older Americans Act criteria. Yolanda also oversees assistive technology. And if you're not familiar with assistive technology, it's really any sort of device or tool, ranging from low tech to high tech, that improves a person's ability to live and function independently. So if you walk with a cane, that cane would be considered assistive technology. If you use Google Home to help you help remind you to take your medicine, that would be a high-tech version of assistive technology. So it's really any kind of device or tool. You know, I know down in the coastal area, AAA, they give a bathroom kit, and one of the things in the kit is a sponge on a stick. And what it does is it helps people reach their feet, right, to help when they're bathing. If they can't bend all the way over to reach their feet, this little sponge on a stick helps them reach it. Well, that's a very low tech, but still counts as assistive technology. So she oversees assistive technology. We have assistive technology labs in every AAA, and I think every Center for Independent Living. So you can actually go to the lab, see the instruments, try them out. Some even have a lending library where you can try them in your home for a little while before you buy. But she also oversees friendly visiting. Friendly visiting is just what it says. It's visiting an individual in their place of residence. But what we're working on is reducing social isolation. As I mentioned before, social isolation has tremendous negative effects on our health. And so friendly visiting helps combat that. We also have telephone reassurance. So in times of COVID, telephone reassurance has really ramped up. And this is a phone call that's made to an individual to help reduce social isolation. And so as people could not go out and do their friendly visiting, we kind of made the switch over to telephone reassurance, and it's been going really well. And even expanding. So we're very proud of that. So Yolanda oversees a whole lot of things. If you need more information, please get with her. And then we have the Georgia Memory Net. The contact for this is Courtney Levy. And if you want to know all about the Georgia Memory Net, you can go to georgiamemorynet.org. It's gamemorynet.org. And the Georgia Memory Net was developed from 3 of GARD's 6 foundational pillars. GARD is the Georgia Alzheimer's and Related Dementias program. It is a state-funded program, and we do contract with Emory University to actually do the work. And what is the work? The work is improving screening and care for people with dementia. And so we have 5 memory assessment clinic locations. There's one in Albany, one in Atlanta, one in Augusta, one in Columbus, and one in Macon. So these people, when they come through the MACs, the memory assessment centers, they can be evaluated and diagnosed with dementia. And then they're offered a couple of options. They could go to home and community-based services, in which case we would send them to the ADRC. And we also like to link them up with the Alzheimer's Association. Now, they may choose not to engage with ADRC or Alzheimer's Association. It's their choice, but we try and make that linkage for them so they get connected to resources that can truly help them on this journey as they are newly diagnosed with dementia. And then we have the GUARD state plan, the Georgia Alzheimer's and Related Dementias Advisory Council. The contact for this is Aline Stone. The GUARD state plan was created to address the needs of, about 150,000 Georgians living with dementia. We have a lot of people in this state with dementia, and it's growing. And so there is an advisory council and collaborative work groups to address the goals that are in the state plan. So we have things like workforce development, service delivery, outreach and partnerships, research and data, public safety and policy. And then we also do Dementia Friends. Dementia Friends is a program to help people, Georgians, understand 5 key messages about dementia, how it affects people, and how each of us can make a difference for people living with dementia. If you would like to become a dementia friend, you certainly can. It's no cost. It's just attending the workshop and then filling out a survey, and then you can become a dementia friend. And if you'd like more information on when the Dementia Friend sessions are happening, please get with Aline Stone. And then we have a couple of other things that we like to dabble in a little bit. DAS works with DHS Offices of Facilities and Support Services, Transportation Services section, TSS, to coordinate a variety of transportation services and increase access across all 12 AAAs. The reason why we partner with TSS is because we know that transportation is a barrier for a lot of people. As we do our needs assessments out in the community, we know that transportation and housing are 2 of the most needed things, as reported by older adults. And so what we do, Tom works as a liaison for DAS and TSS, and they work together to make sure that we are providing the types of trips that people need, and are providing the trips when people need them. We also work with the Department of Behavioral Health and Developmental Disabilities to improve access to services around behavioral health and developmental disabilities for older adults, people with disabilities, and caregivers across the state. We do a lot of work with DBHDD. We sit on a lot of committees, and we do a lot of work with behavioral health and developmental disabilities, and we're really proud of that work. And that's it for me. Any questions?